Hello, everyone, and welcome to today's webinar about hepatitis A vaccination for people experiencing homelessness. My name is Shelley Kaplan, and I'm with JBS International, a firm that worked with the CDC on the communications materials you're going to learn about shortly. Before we get started, I'd like to thank our host, the National Healthcare for the Homeless Council, which was a tremendous help to us along the way. And we're thrilled that we have a lot of speakers with us today. So to give everyone an idea of the flow for this event, we're going to start with 3 CDC subject matter experts, all from the IMS outbreak team in the Division of Viral Hepatitis, where they work on the hepatitis A outbreak. And following those 3 will be our CDC project officer from the Education and Communications Unit at DVH, who will walk you through the new materials. Then the National Healthcare for the Homeless Council will discuss what they do around hepatitis A vaccination. And last but not least, we will feature someone from Heartland Alliance Health in Chicago to talk about how they have implemented vaccine recommendations in their community. We plan to leave some time for Q&A at the end of everyone's presentation, so feel free to submit a question via the chat icon on your screen. And one last thing, if you have any technical difficulties during the event, you can use the drop-down menu in the chat section of your screen to send a message directly to our IT manager, Kyle Miner. Okay, let's get started. As I mentioned, the first 4 speakers are from the CDC. Our very first speaker today is Dr. Martha Montgomery.
Hi, everyone. Yes, this is Martha Montgomery from CDC's Division of Viral Hepatitis, and we're so glad that you've been able to join us. I know it's a busy time for everyone. So I'll be presenting with a few of my colleagues today about hepatitis A vaccination for people experiencing homelessness. So we can move on to the next slide. Great. So we'd like to cover a few different aspects of hepatitis A vaccination. We're going to start by discussing hepatitis A epidemiology generally and how recent outbreaks of hepatitis A have affected people experiencing homelessness. Then Mona Deshani will be discussing the hepatitis A vaccine and how the ACIP recommendations for people experiencing homelessness came about. Mark Wang will be discussing the hepatitis A vaccination efforts to reach people experiencing homelessness during the outbreaks. And then lastly, Amanda Carnes will be sharing some of the communication materials that we've recently developed. So to start off, I'll be discussing hepatitis A epidemiology and outbreaks affecting people experiencing homelessness. So to start from the very beginning, I wanted to mention how hepatitis A virus is transmitted so that we're all on the same page. Unlike the more common viral hepatitis B and C, which are primarily bloodborne pathogens, hepatitis A primarily spreads through the fecal-oral route. So people often think about foodborne exposures when they think of hepatitis A, but in fact, hepatitis A most commonly spreads from person to person through close personal contact, like from a household member or a sexual partner. Common source outbreaks and sporadic cases can occur from contaminated food or water, but these are much less common in the United States. CDC has been recording reports of hepatitis A virus infection since 1966. And you can see here the rate of reported acute hepatitis A cases in the United States from 1966 through 2018. There were some notable increases in reported hepatitis A cases in 1971 and a smaller increase in the late 1980s. Although the risk factor data at the time were limited, these increases were attributed to an increase in cases occurring among people who use drugs. Another important change in the epidemiology of hepatitis A in the U.S. occurred in 1996 when the hepatitis A vaccine was first recommended. After this point, from 1996 to 2011, there was a 95% decrease in reported hepatitis A cases. Unfortunately, in the past few years, we've again seen increases in reported cases. In 2018, there were over 12,000 cases reported, and from our preliminary numbers in 2019, we've had over 17,000 cases reported. So zooming in a little closer at the number of cases that we've seen in the last few years, this curve shows the number of hepatitis A cases reported since 2017 in the blue bars. And the baseline based on our 2011 to 2015 case counts shown by the red line. You can see that we crossed this baseline during 2017, and we saw really significant increases in 2018, which remained steady in 2019. This really represents an unprecedented increase in hepatitis A in the vaccine era. In the last few months, we've definitely seen a decrease in cases, which is good, but it's been difficult to separate the true decreases from decreases related to changes in health-seeking behavior and in case reporting during the COVID-19 pandemic. So the increase in cases in 2017 is really a result of multiple outbreaks across numerous states, mainly occurring among people who use drugs and people experiencing homelessness, and to a smaller degree, also among men who have sex with men. From these outbreaks, 33 states, which are shown by the blue and gray shading on the map, have reported a total of 33,806 outbreak cases, with over 20,000 people hospitalized and approximately 333 deaths reported, although we expect that those number of deaths are probably an underestimate. And then lastly, I wanted to point out the degree to which people experiencing homelessness have been disproportionately affected by these outbreaks. So this map shows the percent of hepatitis A outbreak cases among people experiencing homelessness by state. This information is gathered from what is publicly reported on state and local health department websites, and unfortunately, as you can see in gray, this information is often not reported. For those jurisdictions where we do have information, the percent of cases ranges from 8 or 9% of all outbreak cases to up to 74% of all outbreak cases. Even though in those places where it's only 8 or 9%, this is considerably higher than we'd expect to see among people experiencing homelessness. So it is clear that this population has been disproportionately affected by these outbreaks. And so now I'll hand it over to Mona Deschamps.
Thank you, Martha, and good afternoon, everyone. I shall be giving an overview of hepatitis A vaccines in the United States, followed by the CDC and the Advisory Committee of Immunization Practice, that is the ACIP recommendations for hepatitis A, and later we will dwell into the ACIP recommendations for persons experiencing homelessness. There are 3 inactivated hepatitis A vaccines licensed in the United States. 2 are a single antigen, the Havrix, which was introduced in 1995, and Vacta in 1996. There is also a combination hepatitis A and hepatitis B vaccine called Twinrix, which was introduced in the early 1997. Generally, hepatitis A vaccine is administered as a 2-dose schedule, except for Twinrix, which follows a 3-dose schedule. Next slide, please. This slide looks at the efficacy of hepatitis A vaccines. In a clinical trial, the efficacy of Vacta in protecting against clinical hepatitis A was 100%, and this was a study that was conducted in New York, where more than 1,000 children 2 to 16 years of age received 1 dose of the vaccine, and they were living in a community which had a high hepatitis A virus disease rate. Similar findings were seen with the efficacy of Havrix, which was 94%, and this study, more than 38,000 Thai children 1 to 16 years of age received 2 doses of vaccine 1 month apart, and this was done in a similar setting where the hepatitis A virus disease rates were high. Not shown on this slide, after 3 doses of Twinrix, we saw the similar response. Regarding hepatitis A vaccine safety, during pre-licensure trials and after vaccine was introduced, no severe adverse reactions were reported. Hepatitis A are highly immunogenic, and more than 95% of immunocompetent adults develop protective antibodies within 4 weeks of receipt of the first dose. And a recent study demonstrated that detectable antibodies persisted for at least 22 years after the hepatitis A vaccine was administered. And mathematical modeling and kinetic studies further estimated that detectable antibodies can persist for about 40 years and longer. This slide shows how hepatitis A vaccination was introduced incrementally in the United States, and Martha showed you the nice curve, which really showed you how when vaccine was introduced. In 2006, universal childhood vaccination was recommended. I won't go over this in detail, but you can see the reference to the MMWR articles listed below, which will give you a little bit of the history. In addition to this, several groups which increase risk of hepatitis A infection or severe hepatitis A virus disease was recommended to receive hepatitis A virus. And so this is a list of all the groups and the years they were recommended. You could see that in 2006, travelers, men who have sex with men, users of injection and non-injection drug use were some of the ones which were mentioned on this list. And in 2019, you could see bolded, homelessness was added to this list. Last month, an MMWR article by Nelson and colleagues at the CDC published the updated Hepatitis A statement. So what was new in the Hepatitis A statement? ACIP recommended catch-up vaccination for children and adolescents. There was also a recommendation for vaccination for persons with HIV aged 1 year and older. And the statement also included a consolidation of previous policy notes, and one of them being persons experiencing homelessness. We will now look in depth at the process on how ACIP recommendation for persons experiencing homelessness was introduced. The hepatitis vaccine work group convened for 4 teleconference meetings to reach a consensus regarding adding homelessness as a risk factor for hepatitis A vaccination. The work group followed the ACIP evidence to recommendation framework, which basically consisted of a policy question, followed by a detailed background information and a thorough literature review on hepatitis A vaccination in the homeless population, and 10 sets of criteria were addressed. The policy question that was finalized was, should routine inactivated 2-dose hepatitis A vaccination be recommended for protection against hepatitis A among persons experiencing homelessness? And the population, intervention, control, and outcomes were clearly defined. A systematic literature review of data on hepatitis A vaccine and homelessness was conducted in PubMed, Embase, and Medline Search from a period of January 1st, 2000 through April 25th of 2018. And a total of 273 unique abstracts were reviewed. And of those 35 full articles that were reviewed, 4 articles were included in the final grade analysis, which involved grading of recommendations, assessment, development, and evaluation of critical outcomes, that is, the benefits and harms of administering hepatitis A vaccines. Besides the literature review, the ACIP work group looked at each of the 10 criteria, which had 2 components, judgment and a research evidence section. I won't read through all of them, but just a few so that you get an idea as to what some of the questions that we looked at. For example, is the problem a public health priority? How substantial are the desirable anticipated effects, where we looked at completion rates and benefits of vaccination? How substantial are the undesirable effects, where we looked at how serious are the adverse events of vaccine, and some questions like, is this option acceptable to stakeholders, or if it's feasible to implement? And we looked at various examples of effective venues to conduct mass immunization campaigns, and also explored the state Medicaid expansion as an opportunity to increase hepatitis A vaccine coverage. After a detailed and thorough analysis, it was concluded that desirable consequences clearly outweigh undesirable consequences in most settings. As a result, 100% of votes were received at the ACIP meeting in October 2018, and an MMWR was published on February 2019 stating that all persons aged 1 year and older experiencing homelessness should be routinely immunized against hepatitis A. I will conclude by saying it's very exciting that homelessness has been now added to the immunization schedule as an independent risk factor, and now moving forward, a lot of work and effort needs to be done in implementing this recommendation. And Dr. Wen will talk a little bit more about that in detail. Thank you. And now I'll hand it over to Mark.
Thank you, Dr. Doshani. Good morning, everybody. Thank you for having us. I'll be talking about hepatitis A vaccination efforts to reach people experiencing homelessness. So first, the homeless experience and its impact on health. So people experiencing homelessness experience diseases at higher rates than domiciled persons. They get higher rates of chronic conditions, kind of acute illnesses, and behavioral health issues. The conditions can be more difficult to treat for reasons I'll explain below. These problems with health sometimes lead to homelessness, and homelessness can lead to and exacerbate health issues. It can often be a vicious downward spiral. So persons who are homeless experience greater barriers to accessing care, such as lack of stable address, difficulty with transportation, uninsured or public insurance, and the need to prioritize basic survival, such as food, shelter, safety, before health care. We know that you know this already, but we found it helps to have a framework to articulate this, to remind partner organizations who may not have this population always at the forefront of their minds. So we'd really like to encourage routine vaccination of people experiencing homelessness before there's an outbreak. So one way to improve this is to integrate vaccination into clinics that serve the homeless. FQHCs, community health centers, shelters, mobile clinics, street clinics. It's a familiar setting where providers they know are experienced in caring for persons who are homeless. They have opportunity for education, access to other preventative and health services. But if it comes to it, and as it has been for the past 4 years and counting, as you saw from Dr. Montgomery's slides, vaccination is the cornerstone for outbreak response. We suggest offering vaccination to the following groups to control an outbreak of the type that we're talking about, the hepatitis A outbreak: people who use drugs, people experiencing homelessness, men who have sex with men, people who are or were recently incarcerated, people with chronic liver disease, and these groups can have some degree of overlap. So non-traditional approaches may be needed to bring the vaccine to hard-to-reach populations, because these aren't necessarily the folks who will be coming to your clinic or to your health fair. What's needed is to mobilize the resources quickly. Sometimes what it takes is an outbreak or emergency declaration, and this often from, I'm not a legal expert, but from a resource standpoint, this can open up some resources to do the following activities. We need to pay attention to the storage and handling of vaccines in non-traditional facilities. The hepatitis A vaccine isn't to be frozen, but should be refrigerated. Need to establish contracts to hire vaccinators and to collaborate with corrections organizations and other partners. And finally, develop long-term vaccination policies. We're reaching hard-to-reach populations. Now, the local health departments didn't necessarily all have a systematized list of these venues developed ahead of time, but sometimes they just knew by living in the area that such and such gas station or other area were places where the hard-to-reach populations congregate. So knowledge of these venues and having a list where everyone working on this is aware can be helpful in targeting vaccinations. And establishing partnerships with other organizations that are best poised to reach those venues. And you guys are more amply familiar with those than we are on the federal level. So now I'll talk about two examples. So we're borrowing from their slides, but I'll try to do their stories justice. And a success in West Virginia after a prolonged community outbreak. West Virginia is having over 2,500 cases and counting, 1,250 hospitalizations over a year long. Their response activities included targeted vaccination in high-risk facilities, jails, emergency departments, substance use disorder facilities. They've built relationships with high-risk groups, and they had dedicated staff for outreach to providers. And you can see on the picture on the right, I don't know if you can see their T-shirts, but these are the Hep Angels. They did a lot of work as the part of the dedicated field vaccination teams, having a little more time to sit down, talk with people, address issues of vaccine hesitancy, et cetera. Implementing mobile field vaccination teams. It took effort to do it in a scalable, coordinated, and therefore effective way. So the challenges of setting up mobile field vaccination teams to reach these populations includes some considerations such as logistics, funding, and personnel. So non-traditional approaches to vaccinating persons at risk. This is San Diego County's example, and you'll see some recurring themes. Bringing vaccines to hard-to-reach populations at syringe service programs, homeless shelters, substance use treatment centers, county jails. Not every location obviously has all of these things, but it's a good springboard to think about what your local area has and where one might target vaccination. Building capacity to administer vaccine on site means engaging new partnerships with non-traditional partners. Finally, very important, engaging peer mentors, because these are people who are the population experiencing homelessness may have trust with overall others. It helps overcome mistrust and provides a ready source of effective educators. And so I'll end with this slide, large-scale prompt vaccine response in San Diego County. On the horizontal axis, you have the time starting in November 2016 through December 2018. On the left, you see cases, and you can see the cases spiking in the fall. On the right denote the number of vaccinations. In the fall, a public health emergency was declared, followed by vaccinations being administered right after that, and followed by a drop in cases. And so it's always hard to state causality definitively, but we feel pretty good about this outbreak response. And just remembering that vaccines don't save lives by themselves, it's the vaccinations that save lives. And so this outreach is important, and I'll hand it over to Amanda Carnes. Thank you.
Thank you, Mark. Can everyone hear me, hopefully? Good afternoon, everyone. Today I'll briefly go over some materials that we now have available to reach people experiencing homelessness and the providers who serve them to encourage Hep A vaccination. On this slide, I want to go over some communication materials that are specific to the recent outbreak that you heard Mark and others discuss on hepatitis A that are occurring across the U.S. We have a variety of materials for consumers, including fact sheets, posters, and wallet-sized cards that are available to track vaccine dosage and information on symptoms. Most of these materials are localizable so that you can insert your organization's contact information and location of services. We also have materials for professionals, health professionals, including posters, vaccine hesitancy guidance, and more to support and encourage providers to vaccinate groups most at risk in the outbreak. While we have those outbreak materials I just mentioned, we also have several materials, including a fact sheet and several posters that target people experiencing homelessness specifically and educate them on the importance of getting vaccinated to stop the outbreak. Here we have a website that we just recently went live and updated that outlines the scientific guidance on hepatitis vaccination and testing recommended for people experiencing homelessness, including providing an overview of the guidance and links to the publications and other resources that my colleagues have mentioned. On this page, you'll also find our new communication materials. These new materials, which are grounded in formative research and have input and feedback from key stakeholders, including valuable feedback from members of the National Healthcare for the Homeless Council. These materials focus on a variety of messages encouraging both service providers to vaccinate people experiencing homelessness and messages and materials that encourage those experiencing homelessness to reach out to their providers to get vaccinated. Materials are available in a variety of formats, including customizable posters, digital content for websites or online advertising, and social media content that can be used across different social media platforms. And that's it. If you have any questions, please let us know. Thank you.
Thank you so much, Amanda. This is Lily Catalano. I'm a project manager for the National Healthcare for the Homeless Council. We're very excited to be part of this really important project. I coordinate our clinicians network, which I'm going to tell you all about shortly. And I'll get started telling you a little bit about the work we do and then talk about what we've heard about hepatitis A vaccination from the Healthcare for the Homeless community. And we'll hear more from a clinician working in the healthcare for the homeless field about her experiences implementing vaccination efforts. So as we've already discussed on this webinar, there's this nexus of homelessness and health that recognizes that many people become homeless due to a health issue, and then once a person is homeless, health deteriorates rapidly and drastically. So the National Healthcare for the Homeless Council works on these intersecting issues, knowing that people who are homeless have a higher prevalence of illness, behavioral health challenges, including substance abuse, and on average live 12 years less than the general U.S. population. Our mission is that, grounded in human rights and social justice, we work to build an equitable and high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. So we do this by serving lots of different folks. One group is health centers. There are about 1,400 total health centers supported by HRSA in the U.S. Department of Health and Human Services. And of those, approximately 300 grantees specifically received Healthcare for the Homeless funding. So Healthcare for the Homeless programs began operating in the 1980s in response to the widespread increase in homelessness, and the council has been around since the beginning to support that movement. In addition to the work we do for all health centers, there are a number of other organizations with interest in health and homelessness who are involved in the council either as organizational members or who utilize our resources. They may be shelters or faith-based clinics. We also do a lot of work with medical respite care providers. Medical respite programs serve people who are too sick to be on the streets, but not sick enough to be in hospitals. So it's a critical intervention that can be life-saving, and it's also the opportunity to connect clients with services while they have the stability of a respite program that can help exit homelessness altogether. So many Healthcare for the Homeless programs operate medical respite, and then there are also programs created in different communities to address that need. So the council is where all these folks who are working on different aspects related to health and homelessness can come together and share what everyone is doing. We can support each other and have a common voice on issues that impact the people that we serve. So like I said, we do this through research, publications, training, and technical assistance and advocacy. We host a national conference every spring. We are planning for next year's in May of 2021. If it's feasible to have some aspect of that in person, we will be in Baltimore. If not, it will be all virtual. And we organize our individual constituencies around these three groups. The Healthcare for the Homeless Clinicians Network, which is made up of anyone who provides hands-on care to people experiencing homelessness. The Respite Care Providers Network, which is folks who work in those respite programs that I mentioned a minute ago. And the National Consumer Advisory Board is made up of people with lived experience of homelessness, many of whom have taken on leadership roles in their communities. So those three groups really inform us about what is going on in the field, what the needs are, and then help us create resources that we then disseminate out. So like I said, I work closely with our clinicians network. It's about close to 3,000 members strong of all folks doing direct service who are committed to improving the health and quality of life of people experiencing homelessness. Folks come from all disciplines. We have members from backgrounds like social work, nursing. We have community health workers, doctors, case managers, counselors, dentists, outreach workers, students, anyone working directly with people experiencing homelessness has a place in the clinicians network. We also have a steering committee of 15 people who are elected, and they really inform our clinical agenda and help create resources to share. Some of the resources that we create to support high quality, accessible, and equitable healthcare for people without homes include adapted clinical guidelines on a number of topics. These are developed by experts who provide care to people experiencing homelessness, and they start from standard clinical guidelines and then make recommendations for how practitioners may need to adapt those to take into account the unique challenges presented by homelessness that could affect an individual's health and care. We publish Healing Hand newsletters, which go in depth on topics important to homeless healthcare providers. We host informal webinars that we call coffee chats. We have a Facebook group. And then we gather in person when we're able to at the national conference. So if any of that would be helpful to you in your work, please visit nhchc.org, and you can access all of that for free. You can become an individual member for free. You can even just sign up for our email list if that would be helpful. So the Clinicians Network is so glad to be part of this project to increase hepatitis A vaccination among people experiencing homelessness. As you know, outbreaks have been greatly impacting people without homes, and we know that those folks tend to have more health problems than the general population, so vaccination is so important. We've talked to our community, and many healthcare for the homeless providers are providing vaccination services in a variety of settings and with different partners. So given the many health challenges that a client may be facing when they see their healthcare for the homeless provider, it can sometimes be hard for clinicians to work in the preventive care like vaccinations, among the other many competing priorities. So these new communication pieces that Amanda just shared are so important and helpful in conveying to both clinicians and clients the importance of vaccination and the impact it can have on a client's long-term health. So next, we're going to hear from a clinician who works with clients experiencing homelessness about her work providing hepatitis A vaccination services. I'm so happy to introduce Mary Tornabene, a nurse practitioner with Heartland Alliance Health in Chicago, and Mary is also the chair of the Clinicians Network Steering Committee.
Thank you, Lily, for the introduction, and thank you all for being here today. As stated, poverty and health and housing status are interrelated, and those experiencing homelessness are particularly vulnerable to diseases, including hepatitis. Given the multiple comorbidities that the majority of my patients are impacted by, they are at higher risk for complications from all disease, including most vaccine-preventable diseases. Next slide, please. We know what doesn't work. Some of the routine, long-standing immunization reminders that healthcare providers have relied on for years are not effective in engaging persons experiencing homelessness in their immunization plan. Our reminder cards and vaccine schedules are often lost, tossed, or ruined. It doesn't stop us from giving them out. We also know what does work. Really, you have to own it. Sustainable systems for vaccinating children, adolescents, and adults must be developed within each health system that engages persons experiencing homelessness. Examples of some of the stuff that we do in our clinic, we have nurse-run programs with standing orders that gives staff some independent decision-making and independent practice. It contributes to their empowerment, and we do have a higher immunization rate with that. Immunization care coordination and case management for more transient persons, proper consented use of homeless tracking management software can be of assistance, but again, it needs to be consented. Care coordination around immunizations and preventative medicine and personal reminders also foster support. It really does help. That outreach call to bring people in really is helpful. QI indicators for providers that are, especially those that are coupled with incentives, really can also increase your rate of vaccination. And how do we lower barriers of care for our participants? We know the priorities of food safety and stress of day-to-day living, along with behavioral health issues, substance use disorder, take priority over preventative health care. And outreach-based care, including immunization programs, provide our homeless neighbors with the ease of access to improved access to the health system. It repairs a hole in the safety net, strengthens the relationship between the person experiencing homelessness and the health system, and levels the playing field. Outreach-based services also help to reduce individual barriers to health by acknowledging the lack of mobility, the patient's hierarchy of needs, and the potential for inability to follow through. Immunization strategies, successful, you have to engage the whole team. Successful immunization strategies have whole team engagement and include both health center and homeless service agency staff. As we know, there are powerful barriers that prevent many persons experiencing homelessness from seeking or accessing healthcare services. Competing priorities, like finding food and shelter and mistrust experiences within the health system or the loss of hope, also mean that many people don't seek care. But if you take the care to the persons at shelters, at encampments, at substance use disorder treatment facilities and safety sites, food pantries and soup kitchens, if you do this and there are long-term strategies in place, these long-term strategies have been used by Healthcare for the Homeless team and very successfully. Healthcare for the Homeless teams are uniquely diverse and they provide much more than physical health care. Team members include community health workers. In general, community health workers are frontline public health workers who are trusted members of and have unusually close understanding of the community they serve. In homeless services, community health workers have lived experience of homelessness. They share experiences as part of what makes community health workers unique in their ability to connect with clients in ways providers often can't. Community health workers can provide education, reach out, and bring participants to immunization sites, accompany the health team to places where outreach-based services are provided. They really get clients in for you. Behavioral health teams, substance use disorder treatment teams, and case management are valuable team members that are often on site, at site more frequently, and in places that primary healthcare providers, even healthcare for the homeless providers, aren't traditionally present. And they also assist in bringing persons in for care. Clinical staff, in addition to what was mentioned in the interventions earlier, they do need training on outreach-based services and engagement principles. Next slide. You'll have greater success in outreach-based immunization efforts if you engage workers that persons experiencing homelessness trust. Note that homeless service staff have historically high rates of turnover and may just be a step out of homelessness themselves. And in the time of COVID, they're really forced to become healthcare workers and they have a lot of fear. Be gracious in understanding their limitations related to funding, shelter space, shelter scopes of service, and individual education. Provide training for all levels of shelter staff, but quick conversations go over better than longer ones. Address concerns and priorities of service staff first, and then ongoing public health issues. Focus on how this could help both staff and participants. The more homeless service providers are engaged in physical and behavioral health of your participants, the more they will advocate and reinforce follow through on health issues. Encourage them to encourage their participants to talk to you. It works so well. Collaboration with all agencies providing services at outreach sites will benefit staff and patients alike. Obtain the mutual release of information for each agency your participant works with. It's a great way to properly exchange information. Staff at sites also guide you on the best times to be present, when you can encounter more participants and not interfere with meals or other programming. Next slide. Oh, we're right there. Engaging persons experiencing homelessness and care happens through successful outreach. Patients buy into primary care and behavioral health services. This only happens after multiple consistent encounters. All sustainable efforts in providing health are based on encouraging and engaging participants in care. Unsheltered populations are traditionally more difficult to engage. Unsheltered populations are also on the rise, especially in the largest U.S. cities, and there are multiple reasons why this happens. We use mobile outreach teams in vans, on bikes, or on feet to take the services to people living in the street. Services provided are flexible, non-judgmental, and more negotiated than with other populations experiencing extreme poverty. Show kindness, be consistent and persistent. Do what you say when you're going to do it. Persons living rough have been let down by systems and people more than we can ever be aware. And through an honest, gentle intervention strategy, you can begin to make progress and get them immunized. Find the trusted outreach group or person, collaborate with them. Partner with street-based substance use disorder teams, and allow persons to make their own decisions, even if it's not the one you would like them to make. You'll get there eventually. How do we put this all together? Clinic-based, I kind of really went over that. Additionally, we want to message your staff to discuss immunizations with participants at each visit, and you've got to tell them this all the time. Use resources, partner with your health department. Maybe you can access your vaccines that way. We've been very successful in doing that. Push outreach-based efforts. Successfully reach large numbers in a really short amount of time. Successful individual encounters, as well as multiple encounters through immunization fairs, days, or booths at events, work really well, but you have to use all the resources and put it all together. Reach out, use your team, be on time. Use the new graphics and posters as well. Your team needs to post them 2 weeks in advance. Simply sending them by email or mail to the homeless service agencies, it doesn't work. A member of your team needs to go there and put them up. Make sure you have enough staff on hand the day of the event. Show up on time, work gracious, and work swiftly. Have homeless service agency staff, in cooperation with the available community health workers and case management staff, bring clients for care. Stand with them. If you run short on time or supplies, you must make arrangements to deliver the service to those you missed. Have the conversation, or you won't have success in further events at that site. The word gets out, you left before serving everyone.
Okay, so we covered a lot of things here. I want to thank all of our speakers, and I would like to open up the floor for questions. If anyone has a question, please type it into the chat window. Alrighty, well, if there are no other questions, I want to thank each of our speakers for taking the time to present this important information today, and thank all of our attendees for tuning in, and we hope you'll find these communication materials and all of the advice you heard today very helpful. Have a great afternoon, everyone. Thank you.